Hey everyone, how's it going? Let me know if you can hear and or see me. Fantastic. Good to see you, Tiffany. Or at least read you, I guess. Listen, thank you for joining me. All right, we'll get started here in just a few moments. So if you have questions, feel free to post them up. I did get your prescription assignment posted up. I'm gonna get the other ones graded probably tonight or tomorrow. Sorry for the delay, but you know, stuff happens unfortunately. Hello, hello. Was having some internet issues this morning, so I'm hoping the playback is going to be good, but we shall play it by ear. So, figure worst comes to worst, I do have a placeholder for technical difficulty, so I can just pop this up if need be to go restart my internet connection. Well, hopefully, I'm getting better at this whole streaming thing, but we'll see how time goes. Trying to plan for every contingency possible. So then we'll do this, and then we'll get started for EpiBio at 2:30. So everyone's ready for Journal Club. Should be fun. I hope fun, but we'll see. Hopefully enlightening. Hey, Paige, Molly. Think how lucky you all are. You get to spend the whole afternoon with just me. Something special. Yeah, I don't think anyone. I hope no one's there. It'd be unfortunate. They're not gonna have a very good lecture if that's the case. I'm praying the breakout rooms worked right. I spent all last night like copying and pasting your guys' emails into Zoom, so I am hoping it all works, but we shall see. Randomizing you guys in Canvas was easy enough, but the breakout rooms was a little more onerous. Oh geez, yeah. Nope, it's today. That was the other fun thing too, trying to schedule out all my live streams ahead of time to make sure you guys had the links and everything, but I feel like it's been working out okay. Hey, Nicole? We have our sim on Thursday, that should be fun. Actual simulation, actually. I don't know how the rooms are going to be set up. That should be interesting given our limited capacity, so I'll have to see how Professor Hilton gets that all set up. Hey, Maru. So I'm gonna go ahead and get started here. All right, got the recording going. Looks like about half the class here. I did watch an interesting movie. It was a kind of a fantasy epic. There's this massive battle scene. It had all this huge army going, and right in the middle of it was this half man, half horse sort of creature, right in the middle of the army. And I guess you could consider him to be the centaur of attention, but pretty good film. Anyway, I don't see any questions up on the sticky board, so let's go ahead and switch gears here and talk about asthma. Should be a breath of fresh air, hopefully, for some of you. So we covered the pneumonia, we covered TB, we talked about anaphylaxis and how we might manage that. You'll see a lot of the concepts we talked about in terms of managing anaphylaxis will also have some crossover here for treatment of asthma, because again, you'll see that the pathophysiology is sort of similar. It's just going to be much more sort of specific to the lungs, and you'll also find that it will have, you know, a less severe sort of effect for the most part. I mean, there can certainly be some cases of things like status Manicus, which can get pretty bad. But looking at this, you can sort of characterize asthma as being this reversible narrowing of the bronchial airways. And so our goal, hopefully, is going to be able to relax that and open that back up. And so these patients, and me included, actually have this, I can kind of speak to it, at least from my personal experience, you'll see this kind of increase in bronchial responsiveness. And it could be to a number of different triggers, like for instance, certain animal dander, it could be environmental. There could be cases where you could even have like chemical exposure. So for instance, I've had patients who were cleaning their house and they accidentally mixed bleach and ammonia and ended up inhaling that. It's a very caustic sort of gas, and so that actually induced an asthma attack in them. So you can see a lot of different things that can lead to this, but ultimately you get the wheezing, get the coughing, and all of that. And so certainly there's a big genetic component, which obviously we can't do a whole lot about in terms of our genetics, so we're going to see how we can manage that. But again, the inflammation here is the big issue that's causing the airway obstruction, causing the hyper-responsiveness. So that way, if we are doing things like exercising, or if cold air is a trigger, or things like that, that's what can lead to that airway obstruction and then the clinical symptoms that you expect to see in a patient who is asthmatic, right? And again, we're going to see a very similar process here. So you see these mast cells starting to degranulate, and you can have histamine being released, and you have heparin and tumor necrosis factor and interleukins, all these things that can be released. Also, it's kind of interesting that there is a sort of a longer, sort of a secondary phase that can occur hours later, which can also be problematic, which that'll get into how we manage that in terms of controlling inflammation for the long term for these patients, as we'll see here in just a little bit. So anyway, and again, here's kind of what I'm talking about, where you can have, if you were to look at a graph of like FEV1 over time for patients having a pretty significant asthma exacerbation, you can see that with this early reaction, say, you know, you rubbed a cat on my face or something, I would have probably an early reaction here where my FEV1 go down. And then as time goes on, as the allergen is maybe removed, and then later on you can actually see a late phase reaction, which is, this actually can be the deadly thing if patients are not managed appropriately with things like corticosteroids and whatnot. It's not the immediate phase that's such a problem, because that's very obvious and you can do something about that. It's that later phase that you may not realize, and maybe the patient goes to sleep and then, you know, wake up with a really severe bronchoconstriction that can be a little bit more difficult to manage there. So we'll look at some ways we can deal with this both in the acute phase and in more of the more chronic long-term preventative phase. And that's going to be really important too. So just like we talked about with angina, we talked about ways to treat that acutely with things like short-acting nitrates. There's also things that we did to try to prevent symptoms of angina. So things like beta blockers and calcium channel blockers. There's going to be a very similar sort of mantra or paradigm here that we're going to see, and that's important to keep that distinction. So that way, if someone's having an acute asthma attack, you're not trying to give them something that's like long-acting and takes weeks to work, because that's not really going to help them right in the immediate time frame, right? And just so you can see sort of what's going on here in terms of the different cytokine production that happens here as a result of being exposed to an allergen, you can see things like leukotrienes, and leukotrienes will be really important here, as we'll talk about a little bit later on. But you can see things like this mucus plug getting formed here. You can see the thickening of the bronchioles. You can see all of that occurring, as opposed to what a normal bronchus would look like if they were not having an acute exacerbation, right? So, and you've probably covered a lot of this stuff, so I don't think I'm treading any sort of new ground here. But one thing it's also important to know is that we see that the leukotriene pathway tends to be pretty important here. If you recall, with arachidonic acid being something that gets liberated from the cell membrane, there's kind of two major pathways it could go down. There was the cyclooxygenase pathway, which was the COX enzyme that formed things like prostaglandins. That was important for inflammation due to like injury and things like that. But there's another pathway, and this is the one we're going to talk about today. And this is called the 5-lipoxygenase pathway. This is the enzyme here, which can lead to production of things like leukotrienes. And that's what we're really going to be focusing on in terms of asthma, because that can be an important mediator in causing bronchoconstriction and whatnot. So if we can prevent either production of leukotrienes or maybe block the receptors, then we can hopefully prevent that bronchoconstriction from occurring in the first place, right? Another thing too, if you ever hear of someone who has like, say for instance, like an aspirin allergy, or say for instance, like an ibuprofen allergy or an NSAID allergy, and they say that, cause an asthma attack. That seems kind of odd because it doesn't sound like a typical sort of allergic reaction like you would think of, but it actually does make sense if you look at it from this pathway here. For some patients, they are actually kind of susceptible to this and are more sensitive. If you were to give something like aspirin or ibuprofen and block the cyclooxygenase here, well, what happens to all that arachidonic acid they may be producing? Well, all of it gets shunted from this pathway over to the 5-lipoxygenase pathway, and so they can actually end up producing a lot more leukotrienes than they were beforehand, and that can actually induce bronchoconstriction. So if you ever hear about that, that's actually the mechanism that you're looking at. So if someone says, I have an aspirin allergy, causes me to have an asthma attack, that does make sense if you kind of think about it from the pathophysiologic sort of standpoint here. See, Matthew's asking, prostaglandins cause immediate effects and leukotrienes long-lasting effects on asthma. Is that correct? You're going to find that the cyclooxygenase pathway is not super important in terms of asthma or in terms of like bronchial hyperreactiveness or anything like that, hyperreactivity, I should say, because you could have someone with an acute asthma attack and give them something that blocks cyclooxygenase like ibuprofen, and it's not going to do anything for their asthma. But more so from a respiratory standpoint, leukotrienes tend to be much more important there. That's not to say if you're having like an anaphylactic reaction, you don't have both pathways being active there. So it sort of just depends on the tissue you're dealing with. Leukotrienes just happen to be more important for the respiratory tract. So anyway, as I was mentioning here, you have allergens that are releasing things like, allergen promoting IgE production, which those are really important for leading to mast cell degranulation. And again, you are producing things like some prostaglandins, but more clinically important are going to be the leukotrienes here. That's where it's really going to help us out. Our normal array of different inflammatory cytokines like histamine and things like that are certainly going to be released as well. And then once we have these mediators being released there, that's where you're going to see the smooth muscle contraction within the respiratory tract. And you can also have that vascular leakage, right? Those vessels are going to dilate. And that can lead to bronchoconstriction. You can end up seeing edema that can form here. You can have things like increased mucus production and all of that. And again, you get that more sustained kind of long-lasting phase like 3 to 6 hours later. And that can sometimes be dangerous if they don't receive anything that's going to help to manage them for that period of time. We'll talk about some meds that can actually do that as we get into it. And again, you can find lots of things that can cause, increase in hyperactivity of the airway. You can find that viruses can do this, exercise, cold air, anything like that. The winter time tends to be kind of worse for some asthmatic patients because that cold air tends to cause a bronchoconstriction just because they're so hyperreactive there. Actually, kind of interesting is one way you could diagnose someone with asthma is to actually induce an asthma attack in them. And you're like, well, how would that happen? Well, there's actually a drug called methylcholine. This is actually, if you think about the name, it sounds kind of similar to acetylcholine. And another thing that causes smooth muscle constriction of the respiratory tract is acetylcholine. It's part of the parasympathetic nervous system. And so we can actually find that by giving methylcholine to a patient, if you see a decrease in their FEV1, it shows that reactivity. It shows that hypersensitivity to it. And then that would give you a pretty clear view that, yeah, they probably have asthma. And so then you give them something to reverse it, which we'll get into in just a few moments here. Sounds kind of not very ethical to cause an asthma attack in a patient, but sometimes we'll do this for like research purposes or if we need like a really definitive diagnosis. Most of the time, though, based off symptom presenting complaints and exam, you can pretty well tell if someone has asthma or not, right? So anyway, so we're going to see that other pathways too. Again, the vagal receptors are important here. That's why I mentioned acetylcholine causing some bronchoconstriction. You can even have things like substance P, things like that can all lead to this. And so that's why for some patients, by using multiple mechanisms or different pathways, we're able to get a much better control of their asthma over the long term. So we'll look at some ways we can actually do that. So our therapeutic approaches here, one, we want to reverse bronchospasm. So the main thing we're going to look at is going to be our beta-2 agonist, but some other ancillary meds are going to be things like ipratropium and theophylline. We're going to have the ability to remove triggers or antigens, hopefully, which this is going to be a lesser used sort of class of drugs here. And then we want to control the inflammation. This is going to be good for either like really severe acute exacerbations over the course of a few days, or it's good for long-term prevention of symptoms over the long term. And this will be things like steroids and lipoxygenase inhibitors. I don't recall, do we have anyone in the class who was like a respiratory therapist before this current life that they lead now? If so, let me know. I always like to have an RT in the class, because they can kind of help to supply some of their own experiences and sort of back up hopefully what I'm talking about. Here's an example, as I mentioned, that methylcholine challenge, where you can actually find by administering that, if you cause a significant enough reduction in FEV1, then that would kind of give you an idea, yeah, this is probably going to be something that can, this probably really is asthma, and then you can give them something to reverse that. So if you ever hear of methylcholine challenge, that's kind of what we're doing there. So looking at how you classify asthma here, I'm not going to get into questions on the exam asking you, okay, patient presents like this, they have this many incidents of nighttime awakenings, and they have blah, blah, blah. What category of asthma do they have? I don't really care that you diagnose that. That's for your medicine courses, right? For my purposes here, though, it is important to kind of understand, like, do they have more of a persistent problem? Is it more of an intermittent problem? And how would you manage that differently, right? Obviously, for more persistent things, we may be focusing more so on prevention of symptoms long term, versus if it's more of an intermittent problem, if it's reproducible and predictable, you may not need long-term controller medications for that. You may just need something for an as-needed sort of basis there. But we'll see that when you're kind of managing these patients, there is a definitive sort of stepwise approach you're going to take with this, kind of things you're going to use kind of early on, initial therapies, and then you can add on from there. And so we'll see what some of those options are, and I'll show you a nice graph that kind of shows you that a little bit later on. So as I mentioned, if we can reduce the level of responsiveness in the respiratory tract long term, that can be really helpful, and that's going to prevent us from having asthma exacerbations in the future. So for an example, inhaled corticosteroids can be really potent here. Notice how this is not systemic steroids, right? There's going to be a big difference between those and how they're used for asthma. We're going to see for sort of short-term acute exacerbations, really severe exacerbations, this is where systemic corticosteroids are going to be utilized, right? For more long-term prevention of symptoms, that's where inhaled corticosteroids are coming into play. We're going to look at why that is in a little bit, but to kind of clue you in, if we can use something that is targeted against one specific area of the body or one particular tissue, that's going to help us to mitigate a lot of the systemic side effects that we would normally see with that class of drugs. So we'll get more into that in a few moments here. And then again, they're going to want to prevent and reverse acute bronchospasm. Okay, so if we can do things like avoid allergens, or if they can avoid their triggers, for instance, if they can stay away from, say, pets or something, if that's a particular trigger for them, or if they undergo some sort of desensitization from like an allergist or something like that. And then for those acute exacerbations, this is where we're going to look at things like our beta-2 agonists. That's going to be kind of your go-to. So again, if you have someone who has like really intermittent symptoms, they may only need a short-acting beta-2 agonist for the cases where they're going to go work out and they know that exercise causes bronchospasm, or if they know that they're going to be exposed to a certain allergen, and that's the only time they ever have an asthma episode, then they may only need the beta-2 agonist, right? Versus if it's more of a long-term sort of issue, then they may need more kind of long-term medications to go along with that. And so that's one thing I want you to know at the end of this, is sort of how we use these medications differently from one another. Okay. So for our quick relief medications, this is where we get into our short-acting beta-2 agonist. This is going to be kind of our go-to. This is like your short-acting nitroglycerin for angina sort of treatment there. We're going to see things like anticholinergics and then systemic corticosteroids. These are good for relatively quick relief, talking about in the course of, say, hours or so, right? For more long-term control of and prevention of symptoms, that's where we're going to get into our long-acting beta-2 agonists. We're going to have our inhaled corticosteroids, leukotriene modifiers, or usually these are going to be leukotriene antagonists, the receptor antagonists. We'll talk briefly about mast cell stabilizers, but these are not used nearly as commonly. Talk about some anti-IgE antibodies, and then the methylxanthines. And in fact, some of you may be consuming a methylxanthine right now. In fact, I have a nice methylxanthine in my cup currently. We'll talk about what that is in just a little bit. Trying to add some production value by getting some props and things like that to help enhance your learning. But anyway, so getting into our beta-2 agonists, we've talked a lot about the sympathetic nervous system and its various effects, whether you're activating alpha-1 receptors, beta-1 receptors. Now we get into the beta-2. And in general, as a kind of a a standard, you can kind of think about beta-2 agonists or beta-2 receptors causing bronchial smooth muscle relaxation. Really, they cause smooth muscle relaxation across the body. So if you imagine activating beta-2 receptors on the blood vessels, that causes vasodilation. If you cause the activation of beta-2 receptors on the bronchial smooth muscle, it causes relaxation. And it does that by increasing levels of cyclic AMP, and then that causes the relaxation to occur, usually by blocking calcium influx and things like that, right? So we have a couple of varieties of beta-2 agonists. We have our short-acting ones that usually last between 4 to 6 hours or so, and then more long-acting varieties that can last throughout the day, normally about 12 hours, so it's usually like a BID sort of medication there. Some of the common things we're going to see is that these beta-2 agonists don't just work in the lungs, they're going to work elsewhere as well, especially depending on the dose that you're getting there. And in fact, if you were to look at, say, for instance, like an oral form of some of these meds, which is used rarely, you'll actually find that the systemic side effects are much worse than it would be if you just had an inhaled form via like an inhaler or something like that. And just even an example how this works, if I activate beta-2 receptors here, I'm going to increase cyclic AMP, and this is going to help to prevent this coupling here between calcium, calmodulin, all of that, so that way the bronchial smooth muscle can relax, right? It has sort of an inhibitory sort of effect there. So here are the different forms we have. For short acting, we have two primary ones. There's albuterol, which is ProAir, Ventolin. A lot of brand names are out there for that one. And then we have levalbuterol. Now, being that we are in Orlando and Lord willing, we ever have travel again. Orlando is a big travel hub, right? This is something to where, we have a lot of patients coming in from outside of the country that may have different names for medications. And so if you ever hear the term salbutamol, that's actually going to be what the patients from the UK call their albuterol. And so just as an example of sort of a common British name for medication for a med you'll see all the time in the US. Now, for whatever reason, and I forgot to mention this, but your third prescription assignment is posted up on Canvas now. One of them is to write a prescription for albuterol. And for whatever reason, I always have like a tenth of the class that like puts salbutamol on their prescription. And putting salbutamol on a prescription and then sending that off to CVS or Walgreens or something, I think would be kind of like going to, McDonald's and saying, I want a Royale with cheese, right? It's technically correct, but it's just not kind of what how we term it here in the U.S. And so you probably get a few funny looks or a phone call from somebody about that, perhaps. But just put albuterol. It's what we use here in the States, and so that's what we're kind of going with as our standard. Some of you may go off and practice in other countries, and I totally advise use whatever the local nomenclature is. But here it's albuterol. I love Pulp Fiction too. It's somewhat inaccurate with this drug references, but that's okay. I'm not going to hold it against them. Again, typically we don't stab epinephrine through the heart, through the sternum. That's rarely to never done, but it is quite exciting when you see it. Anyway, so we have the short-acting kind, we have albuterol, and then we actually have one of the enantiomers of albuterol, the left-handed form called levalbuterol or Xopenex. Some people feel it has a better side effect profile than others, but really it's just because it's relatively a lower dose of albuterol, and there's some issues with the studies there. But regardless, some people will say they swear by it and they say levalbuterol is what I use and that works way better for me. It is what it is. It's usually pretty expensive. So if I have a patient comes in saying that, oh yeah, I'm on Xopenex, I'm like, well, you got your home supply? Because we don't carry that. It's too expensive. But then you're going to have some long-acting forms. This is an important thing here. You do not want to use these by themselves for asthma. If you're going to be using these for asthmatic patients, it has to be in conjunction with an inhaled corticosteroid, which I'm going to be talking about in just a little bit. But I include these here because, again, we're keeping it within the class because it has the same mechanisms. So you have things like formoterol and then salmeterol. So kind of the urol is sort of or terol, I guess, would be the suffix here. You could use to identify the beta-2 agonist if you want to use that to keep in mind there. So the adverse effects are directly linked to the actions that it has on beta-2 receptors, but recall that no drug is completely 1000% specific for just its one receptor. Sometimes you get some crossover effect here, and so you can see effects on the heart, for instance. Even though it's called a beta-2 agonist, there can be some beta-1 effects as well. So you can see things like tachycardia. You can see hypotension related to beta-2 effects causing vasodilation there. You can see things like headache and dizziness associated with that as well. Imagine if you're activating beta receptors on the skeletal muscle. You can see tremors. You can see hyperglycemia because it can do things like stimulating gluconeogenesis from the liver because, it's like simulating a mini fight or flight sort of response. So a lot of these things are all directly related to its own mechanism of action there. Some other things you may see as being useful, I don't mention it here, I think I talk about this next semester, but it can also cause things like decreases in potassium. It can actually cause a shift of potassium into the cells, leading to a sort of transient hypokalemia, and that can actually be used for our benefits if someone did have hyperkalemia, for instance, here. But so anyway, so these side effects are going to be directly related to like the dosage form they get and like how big of a dose they're getting. So for instance, if you have someone who is getting oral albuterol, which is rarely used because the side effect profile is so bad, patients get super jittery, they get tachycardic, they get dizzy as a result of having that big of a dose there. And then if you were to compare a couple of different dosage forms from an inhaled standpoint, some of you might have heard of a nebulizer versus something like a metered dose inhaler or an MDI. Again, the doses are quite different there, even though they both have their own roles to play. With an MDI or meter dose inhaler, you're getting a very specific quick dose. It's like 90 micrograms for albuterol. Versus in a nebulizer, which is basically you put the liquid medication into this tiny cup and it vibrates at really high frequencies and allows the medication to be nebulized, and then it kind of forms this nice mist that the patient can kind of breathe in passively. That's really good for like children or people who can't really have the dexterity to use an inhaler. And so again, I remember growing up as a kid, whenever I would have an asthma exacerbation that seemed a little more severe than usual, typically due to like viral infection or something, my mom would bust out the nebulizer. My brother and sister would, make fun of me relentlessly for it. But I remember getting that really big dose of albuterol. I could breathe totally fine afterwards, but I was so shaky as a result of that big of a dose of the medication, essentially, right? So again, it all has to do with how big of a dose is being administered, and the dosage form can make a difference there. So switching gears, these are going to be our inhaled corticosteroids, and these are going to be very familiar to you if you recall the nasal corticosteroids we talked about back in the ENT section. And so this includes things like beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and triamcinolone. If you can recognize the brand names, that can be useful in helping you to recognize what dosage form you're dealing with. So for instance, with like budesonide, it's Pulmicort for the inhaled form and Rhinocort for the nasal form. That makes pretty good sense. Pulm for lungs and Rhino for nose. Makes good sense there. Or Flovent for the inhaled form, Flonase for the nasal form. Again, it's important not to get these mixed up, and it's a common medication error that can occur, right? So for instance, if I see like an asthmatic patient who's being admitted to the hospital, and I see that they have albuterol on their list, and then they're on Flonase, but no inhaled corticosteroid, that's something I'm going to question, because if the nurse just put down fluticasone on the medication reconciliation and then just picked the first thing that came up on the list that popped up, just like when you search for anything online, you get a whole list of things. If they just click the first one there, it might be the wrong product. And so you do have to be cautious with that and make sure you get the right kind. So I would question that. I would say, well, they're an asthmatic patient. They're being admitted for asthma. Are they not on some sort of inhaled corticosteroid? They might not be, but you got to ask the question to know, right? So these are very good for helping to control inflammation over the long term. And so patients are going to be using this to prevent asthma attacks over the course of, say, weeks to months. And similar to that, they take a long time to kick into action, whereas with systemic corticosteroids, within a couple of hours, they should be kind of starting to work. Here, they can take up to 8 weeks for maximal effects. And so this is the problem, is that patients will start to take it and not really notice any differences, and that may lead to them to discontinue it early. But they need to stick with it. And the other thing too is that they stop taking, because now that all of a sudden they've been taking it for 6 weeks, they feel a lot better. They're not having to use their albuterol inhaler nearly as much. Then they stop taking it because they felt better, and then their asthma symptoms come right back. So it's important to let them know that, hey, consistency is key with these. If you stop taking it, it's going to go right back to normal, right? So that's important to know in terms of how they work and how long it takes for them to kick in. The anti-inflammatory action, or I'm sorry, with the adverse effects here, some things you want to notice are going to be related to its anti-inflammatory actions and the other effects it has, because they are corticosteroids. You're going to see that they can cause things like growth suppression in children. This is typically like really high doses. The benefit of inhaled corticosteroids is they really just work locally in the lungs. You don't really see a lot of systemic absorption unless you're on particularly high doses or you're dealing with very small patients. And then you may see some inhibition of the immune system, but again, this is likely to not be a very big clinical effects, especially for otherwise healthy patients. However, this is one important thing to note with this class of drugs here, and I'm going to go ahead and highlight it because I think it's important, is the oral candidiasis or thrush that can occur with this, right? What is this? Basically in the back of the throat, you might notice these nice white plaques that are forming here. A lot of that is due to local immunosuppression. Normally, patients may have candida that enters into their oropharynx and they don't have any problems with it because they can fight off that infection with their competent immune system. But by getting the stuff on the back of the throat, because when you inhale drugs, it'd be nice if everything went nice and cleanly down into the respiratory tract, but that's not how it works unless you had like an endotracheal tube in. Some of it's going to hit the back of the throat, some of it is going to be swallowed and go down into the stomach, and some of it is going to go into the respiratory tract where you want it. However, the stuff that hits the back of the throat can lead to local immunosuppression and can lead to a thrush infection. Again, this can be treated with some of the antifungal drugs we talked about before. Things like nystatin is a very good one because it doesn't have any systemic absorption. Just swish and swallow or swish and spit, and that can help to treat that. The biggest patient education point, though, is to prevent this from occurring. And so after they use their inhaled corticosteroid, have them wash their mouth out. Have them just do a little gurgle of water, it's fine, and then spit it out. That's going to help to prevent that from occurring because it's going to wash off the drug and prevent any kind of local effects from kind of sitting there and festering, right? So, and then sometimes you'll actually see the combination of a long-acting beta agonist plus an inhaled corticosteroid. This kind of has a nice benefit because one, they're synergistic in the fact they have different mechanisms, but also while you're waiting for the corticosteroid to sort of kick in over the course of weeks, the long-acting beta-2 agonist sort of starts to work right away. So you can have something like formoterol and budesonide where the formoterol is kind of working day and night over a 12-hour period each time you get a dose to prevent that bronchoconstriction from occurring because those beta-2 receptors are kind of constantly being activated. And then the steroid is taking time to also kick into play. And then with the two are working together, it's really nice. So I'll give you an example. When I was a kid, and again, I like to use this as a personal example just because I think it helps drive the points home for you guys, that, I used to be a very poorly controlled asthmatic patient. I had an inhaler in my pocket at all times going to school and stuff. I'd need it several times during the week. I was not very well controlled. Not that I really knew any difference. I just thought that was just my inhaler. And again, this is like elementary school. And then I actually got put onto a combination of salmeterol and fluticasone or Advair. Started taking that regularly, and I just didn't need the inhaler anymore. It was fantastic because I had a nice 24-hour sort of coverage there. Now, if I did have an acute exacerbation, using Advair or something like this is not going to be useful for that. These are long-acting medications. They're not good for short acute exacerbations. Okay, so I want to keep that delineation in mind, but you need to be able to know what to do for an acute exacerbation and then what to do to prevent those symptoms down the road. All right, so those are kind of like your staple medications. That's what most patients should be using for the most part, both in terms of like acute treatment and then also for long-term control. Some additional meds we can use as well in order to help prevent symptoms include things like our leukotriene modifiers. There's really one drug in this category that we use regularly, and it's called Montelukast or Singulair. And this is going to be a leukotriene receptor antagonist. It'll block those receptors there and prevent some of the inflammation, bronchoconstriction, and things like that, mucus secretion, whatnot. Jackson's saying, my brother is terrible about compliance and uses his rescue inhaler very often. Yeah, and again, it's a tough thing because especially like inhaled corticosteroids, you're using it, it doesn't seem to be doing much at all. And plus, some of these meds are like really expensive. So if you don't have insurance coverage, it's difficult to get controller medications, at a reasonable price. So it's a tough thing for sure. And so actually what's interesting here is that Singulair is actually good for aspirin-induced asthma, which makes total sense based off of what we talked about before of how aspirin-induced asthma is that shunting over to the leukotriene pathway, right? So it makes sense why you can do that. Typically we'll make sure you'll recommend taking this at nighttime. There's a thought that this is good for patients with like nighttime awakenings because your body tends to, just due to the nature of a circadian rhythm, tends to produce more leukotrienes at nighttime. The thought is if you take this at bed, it will then help to prevent those nighttime symptoms. I don't know if there's any studies that directly show that, but that's the theory behind it at least. Very rarely do we use a 5-lipoxygenase inhibitor, but this is called Xilutin. This is going to be actually an injectable medication. So before with like albuterol or inhaled corticosteroids, long-acting beta agonists, those are all inhaled medications. Singulair is actually an oral medication, so that's another thing from a compliance standpoint that could be beneficial to some patients. This one's going to be an injectable because it's actually a 5-lipoxygenase inhibitor. It's a protein, and so can cause a lot of issues like flu-like syndromes because you're having a reaction to the protein. Can inhibit some CYP enzymes. So this one is not really very often used unless patients are really poorly controlled otherwise while being compliant with other regimens. And again, as I mentioned, so you could either do things like blocking the actual leukotriene receptor itself, or you could prevent the 5-lipoxygenase from working. Generally, though, if you need something to work on the leukotriene pathway, just go with Singular. That's what most patients end up using anyway. It's much more cheaper and safer from a side effect profile. I didn't even mention anything for Montelukast because it's so benign. Also, in terms of efficacy, pretty wimpy in terms of, especially compared to something like inhaled corticosteroid. But for some patients, it's a nice add-on to get some good synergy from that. So actually I put the side effects here, and even though it lists kind of a lot of non-specific things, there's not really a whole lot patients are going to experience for the most part. It's a very benign medication for the most part. So some other things you could do potentially, and again, these are not frequently used here, but you could do things like applying mast cell stabilizers. So you could do things like Cromlin or Netocromil. We've mentioned these previously in talking about ENT stuff for the nose. Very similar to that is that, again, it doesn't do anything for an acute exacerbation. Has to be taken before the insult has occurred, right? Before the allergen comes in and actually triggers the bronchial hyper responsiveness. And again, we just don't use them very frequently, but that's one thing maybe patients are using if they've kind of failed other therapies. Again, you can see here, these are both inhaled products, and they do take some weeks to work. They have to be taken regularly, just like the corticosteroids. Otherwise, they're really not going to see a lot of benefits. Okay. And again, you expect to see sort of from a side effect profile, pretty benign stuff here. With inhaled products, you can always get some bad taste in the mouth. Other than that, it's pretty non-specific. So, and again, these just aren't used that frequently. I don't think I've ever seen a patient on inhaled form here, but you at least want to be familiar with it if you do see it. So this one I do see a little more frequently. I see a lot of patients, at least at Nemours, who go into the clinics to receive this drug. It's called omalizumab or Xolair. And so already you know something about this drug just by seeing the mab on the end of the name there. So monoclonal antibody. Just like, monoclonal antibodies were in the news recently. I'm sure the president had contracted COVID, and he actually got an experimental medication that was actually 2 monoclonal antibodies to help treat that. So again, it's a booming business to produce these monoclonal antibodies, but again, they all share similar issues with them in terms of risk for things like anaphylaxis and whatnot. But basically, this particular monoclonal antibody, again, they all have their own specific targets. This one in particular is targeted against IgE. So because we know IgE is so important for the inflammatory pathway in asthma, by neutralizing IgE, that helps to prevent the IgE from activating all those mast cells and cause them to degranulate and all that good stuff, right? So it's very powerful and it's very good for what it does without causing necessarily the same side effects like you would see from someone taking corticosteroids chronically. But it can be very beneficial for patients who are poorly controlled, even while maximized on things like long-acting beta agonists and long-acting inhaled corticosteroids. But there is some risk associated with it. So again, this is an injectable product. It is a monoclonal antibody. The patients have to come into the clinic to receive it, and they always have to be watched for things like anaphylaxis. There is some small risk for like secondary malignancy, so that's also another reason why we don't like to use it until they've kind of failed everything else. Again, it's going to be quite expensive as compared to something like Singular would be. You can see things like urticaria and anaphylaxis being quite rare, but you do want to be aware of that, so that way if your patient does develop an anaphylactic reaction, you know exactly what to do for it. So you guys already know the drugs to use in those cases there, right? All right. Next we have our Methylxanthines, and so this is again a not frequently used class of drugs, but if you say, for instance, work in the ICU, this may be something you see occasionally. Marley's asking, just to clarify, is that considered another form of mast cell stabilizer? Not directly, because if you're looking at like Cromlin, for instance, that is directly affecting the mast cells. With Xolair, that's more preventing, it's neutralizing IgE so that way it doesn't interact with the mast cells. So I wouldn't call it the same class because it's not directly stabilizing the mast cells. It's just preventing them from ever being degranulated due to the actions of IgE. So I'd kind of keep them separate in my mind a little bit because they are used a little bit differently there. So if that makes sense. So Methylxanthines, this is going to include, and I include this here because we don't use it frequently for asthma, or we used to use it a lot more actually. This is a very old school set of drugs. But you'll still see it used for COPD occasionally, and then I've seen this used for like really severe cases of status as Manicus in the ICU before. So Methylxanthines do a couple different things for us, and the main agent in this category here is actually theophylline, or if you ever see the IV forms called aminophylline. And as I kind of alluded to, some of you may actually be utilizing or maybe even abusing some methylxanthines right now just to stay awake through this riveting lecture. So it's actually caffeine fits into the same category. Caffeine and theophylline actually fall into the same category, just like you don't want to give chocolate to dogs, and that's because chocolate actually includes a product called theobromine, which also fits into this category as well, and their bodies can't process that. So the reason why we didn't necessarily like it from a long-term management standpoint is because it doesn't seem to be as effective as inhaled corticosteroids. However, it's been around a lot longer than those have been, and it has a very narrow therapeutic index. You gotta be really cautious when using this, and getting the levels incorrect or getting them wrong can lead to things like arrhythmias, seizures, and whatnot. And these drugs are almost entirely renally eliminated. So I've had one case actually where a lady was in a nursing home long term. No one, she'd been probably on theophylline for like 20 years or something, and cup number 6 of Joe today. Yes, I can certainly agree with that sentiment. But basically, she'd been in the nursing home for a long time, wasn't really being watched that closely, and no one really went back and looked at her renal function to see that it had been diminishing over time. No one went back and actually readdressed her theophylline dose, and so she ended up accumulating quite high CNS levels of the drug and came in seizing, right? So this lady who was otherwise just kind of sitting there, poor renal function, but otherwise healthy, all of a sudden theophylline levels got too high, started seizing. No history of seizure ever. So she actually comes in and found that the CNS levels are quite high. We were able to do blood levels, and we were able to kind of extrapolate what those levels would be in the CNS, and they were just really, really high. And so she ended up ultimately dying, unfortunately, because she just could not clear the drug out in time, and we could not really get it out without the patient having kind of irreparable harm to the brain, unfortunately. So very unfortunate case. And again, be careful if you see patients on theophylline to make sure someone's at least addressing the dose that they're on and their renal function. Is caffeine renally eliminated? Yes, it is renally eliminated to some degree. And actually, you could probably pull up the lexicon. I might do that later. So you can actually see what the metabolism pathway. There is some hepatic elimination, but mostly it's going to be renally eliminated, at least for theophylline. I don't know if the balance is a little different for caffeine. But anyway, so you're going to see this probably used more so in COPD because it has this ability to inhibit phosphodiesterase. And if you recall, we talked about that previously with drugs like sildenafil. We talked about this with positive inotropes like milrinone and amrinone. But basically, by increasing levels of cyclic GMP within the bronchial smooth muscle, it causes relaxation. Also can actually block the effects of adenosine, which is, we talked about adenosine in terms of actions on the heart and SVT, but by blocking adenosine in the lungs, that can also cause relaxation of that bronchial smooth muscle as well. There's some anti-inflammatory actions with it additionally. However, the side effects are quite severe. So just like you see with caffeine, having too much caffeine can cause you stomach upset because it stimulates gastric acid secretion, cause diuretic effects. All of those seem to be pretty similar. It's just the often tends to be a little bit stronger than you would see with something like caffeine, but the similar actions can still be occurring here. And then the really high levels, which I don't care that you necessarily know which level specifically, but can lead to things like seizures and arrhythmias. So that was really the challenging thing with these patients when they get really high levels. And this is kind of the thing we try to avoid for patients because, again, you have to do blood levels, and it's just, the narrow therapeutic index makes it kind of untenable when we have good things that work better, like inhaled corticosteroids. You'll still see it occasionally. And just give you an example of just what our therapeutic levels are, between 5 and 20 milligrams per ml is therapeutic. But even once you start to get up to 15 to 20, the upper end, that's where you start to see things like nausea, vomiting, cardiac effects. So it's just a really nasty drug here, especially if you're not watching the kidney function. So some other drugs you can see used occasionally include our anticholinergics. And so these work by blocking the muscarinic receptors to take the effects of acetylcholine off of those muscarinic receptors, causes bronchodilation. We have two in this category here, including ipratropium and then tiotropium, or Spiriva. Atrovent is for ipratropium. Jackson's saying, would these thresholds change in someone with high tolerance due to frequent use, say someone like Kay? It depends on the person, I think. You can develop some physiologic tolerances, but not everything develops tolerance at the same rate necessarily. Same thing kind of applies to opioids too, which I hope no one's on their 6th dose of opioids now. But you can see that, you know, they may be really tolerant to a lot of the CNS stimulant effects, but maybe the effects on the heart, maybe not so much, and they can develop arrhythmia. And so you'll even see cases of this with patients who have abused too much, like Red Bull and things like that. They can develop arrhythmias even though they may not have had a seizure, for instance. There's a website out there called Death by Caffeine. You can actually go on there, put in your weight and your caffeine du jour, and figure out how much you'd have to ingest to actually be a lethal dose. Turns out for most people, you'd have to drink like liters and liters and liters of coffee, to where it would be, you'd probably throw up before you ever got even close to that dose there. But you know, if you had someone who was trying to stay awake and taking a bunch of no-dos, that's much easier to get close to that, you know, toxic to lethal dosing range there. Yeah. It's okay, Kay. I'm right there with you. It's all about maintaining the baseline. It's the withdrawals we're trying to hold off on right now, right? Yeah, kids are ordering powdered caffeine. Absolutely, that's the big issues you run into, or like you see, like, you know, truck drivers and stuff, or people have to be awake for really long periods of time. That can be a big issue for them as well. They're taking so much of that stuff. So, anyway, with the anticholinergics, sometimes you'll see ipratropium being given at the same time as albuterol, and some of you may have seen this if you worked like in urgent care or like an ER. If you ever hear someone call something like a duaneb. A duaneb is basically a combination of albuterol and ipratropium being given at the same time through a nebulizer. And so that's a common thing you'll hear in clinical practice. But albuterol is typically given by itself. And if you need to, you can add on ipratropium. You generally are not going to see someone with asthma getting ipratropium by itself. Okay. Rarely would you see that. On the other hand, though, you may occasionally see patients who are with COPD getting tiotropium or spiroviva by itself. That does make some sense because, again, their mechanism for injury is a little bit different there. Let's see. It was a go-to med in our ER for asthma exacerbation. Yeah, so, Andrew, so it's probably a combination of albuterol and ipratropium, so you get the duaneb kind of going at the same time there. And Matthew, I'd encourage you not to drink 60.9 cups of coffee. That would be quite a bit of coffee there. Although I'm drinking cold brew, so it's even more concentrated for me. So hopefully this is not near my toxic or lethal amount. I don't think so, though. Anyway, what are those common anticholinergic side effects that you might run into? We recall these. We talked about these before, but again, this is a good mnemonic to remember. This is a handy thing just for rotations or the boards and things like that. But anticholinergic effects, antimuscarinic effects, or things like blind as a bat, mad as a hatter. You guys kind of know this. I don't need to belabor these points by themselves. But remember, sometimes they're getting drugs at the same time that can cause similar effects. So it's hard to tell which one's doing it. So if you had someone who got a duaneb, albuterol, and ipratropium, and they were tachycardic, I couldn't necessarily say it's because of one drug or the other, or it's because of their anxiety because they're having an asthma attack, or for a variety of other reasons. So again, these are things to associate it with it, but it may be difficult to tell what the particular culprit is at any one time. So, what would you need to do, though, if you have someone who's coming in for an acute exacerbation, like to the ER, or they're in the back of the ambulance? Like, what are you doing for those patients? Well, initially, the biggest thing is to get the smooth muscle relaxed, right? So that's where our albuterol comes in. That's where ipratropium comes in for the acute management. Usually on the outpatient side of things, they'll just be taking albuterol for that. If they are still needing some extra help, this is where our oral systemic corticosteroids can come into play. Sometimes we'll actually use parenteral depending on how severe the exacerbation is. But again, this is helpful over the course of hours to days to help us to prevent any further bronchoconstriction from happening here. So again, these would work if you had patients taking these orally all the time. This would be great for their asthma, but it's awful from all the other side effects they'd have, like their hyperglycemia and their mood changes, and causes weight gain, all the kind of different things you'd see with long-term corticosteroid use that we don't want to do. But for an acute exacerbation, 5 days worth, typically not a big deal, right? From a side effect profile, I mean, it may get a little loopy there, but for the most part, you're not going to run into a lot of chronic issues like you would see with long-term systemic steroid use. What are the common ones? We've already seen these before, but things like prednisone or prednisolone are pretty common. Dexamethasone, either given orally or as a parenteral product, and then methylprednisolone is typically a good IV one. So if I have someone who's like coming in and they're a severe enough exacerbation where they're getting admitted, typically we'll put them on something like IV methylprednisolone Q6. If they're going to go home, we may just put them on prednisone or dexamethasone. That's kind of what I most commonly end up seeing there. For little kids, usually prednisolone is pretty reasonable since it's liquid. And again, remember the side effects here. The longer they're on it, the more likely you are to see these things happen here. But again, for a short 5-day course, not a big deal. However, if they're in the ICU for a week or longer on these steroids, this is where the stuff becomes more of a concern. And again, if you're on it for more than a week, you have to taper off to make sure you don't develop that adrenal insufficiency. Okay. So what is sort of the pathway here for these patients in terms of managing of their asthma? And again, this is more for like outpatient chronic long-term management here. Most of them are going to require short-acting beta agonists as needed, right? So a SABA, that's going to be on your prescription assignment. Remember, albuterol is typically the go-to for 99% of patients. Some patients will use Xopenex, but it's not super common because it's usually way more expensive. Next off, they're going to be more persistent, right? So just for intermittent asthma, they may be on a SABA by itself. For more persistent asthma, this is where they're going to have the as-needed short-acting beta agonist plus something like a low-dose corticosteroid. This is what the majority of patients are going to be on. If they couldn't be on that, then they could be on some other sort of controller medication, maybe a mast cell stabilizer, probably more likely singular leukotriene receptor antagonist, very unlikely to be theophylline, though, just because it has that narrow therapeutic index. And then as you kind of go up, then you're going to see, okay, well, if that's still not managed very well, if they're more moderate or severe, then you consider using like a combination, long-acting beta agonist plus an inhaled corticosteroid. Remember, for asthma, we don't do long-acting beta agonists by themselves. Sometimes you'll do that for COPD, but not for asthma. There's actually been shown to be increased mortality. So definitely at least want them to be on the inhaled corticosteroid by itself or plus the long-acting beta agonist, right? And you can play with the doses. You can keep going up on the steroid dose potentially to get better control. And again, it's a stepwise sort of approach here. Typically, what you're going to find is as things go up and things get more severe, the more likely we are to start to consider things like Xolair. And again, that's tough because it's every 2 weeks you're having to come into the clinic to get it, which, you know, if they're a kid and the parents have to schedule for that, it can be a challenge. But again, the alternative is them having to be admitted to the hospital several times a year, which is obviously problematic in and of its own sense, right? So again, if I tell you a patient has, you know, they're on this regimen right now, but they're poorly controlled, think about what the next thing you would want to add on might be. And make sure it makes sense based off of what they're already taking, the mechanisms there, and what you might add on to it to get some additional synergy, right? So I've already said that they're like on maximal doses of inhaled corticosteroids, long-acting beta agonists. What could be next? You could consider leukotriene receptor antagonists. You can consider Xolair. You can consider all these different things at that point, okay? So just something to think about. So some things we can do to help out our patients in terms of inhaling medication. I'll talk about the general steps for using an inhaler, but some additional tools we can use to help those patients out include things like spacers and then valve holding chambers. And so basically, I don't have a picture of these. I don't have a picture of that necessarily. Let me pull up. I'm going to use my incredible art skills because I know you guys have been missing those from these lectures here. So imagine if I were to have an inhaler here. So this is like a metered dose inhaler. There's the actual mouthpiece, and then here's the drug here. And so you press down on this, and then you get a bunch of medication spritzing out, right? And ideally, your patient's mouth will be sort of on the mouthpiece there. But this is tough because there is some dexterity and there's some technique that goes into this. And the biggest place where I think that like RTs especially can really help us out as being a part of the team is like good education for these patients, because if they're not using their inhalers effectively, they're just wasting their money. They're just more likely to come in for exacerbations. And technique is so important. So like I help out with this, and depending on my role with inhaler education, RTs are even better because that's their job. That's what they do all the time. So they're really, really good at it. So the problem though is that like you have to be able to coordinate effectively in order to use these inhalers appropriately. So instead, what we can do is some tools to try to help facilitate better use of these medications here, and that's where we can have things like a valve holding chamber or a spacer. So basically, it'd be a thing you'd sit on the end of the inhaler here. So basically it's a chamber that will actually hold all the medication in place right here, and then when the patient's ready, so I can basically depress the canister, drug goes into the spacer, and then when the patient's ready, they can breathe in on their own time. This is good for patients that have like poor dexterity. Like imagine if they had like rheumatoid arthritis and their joints were deformed, or if you had like a kid or something like that. This can be a big help. And it even has like a nice like little whistle sound it'll make if you're breathing in too quickly, because also the speed of inhalation can affect how much drug actually gets into the lungs as well. So if you ever see a valve holding chamber or spacer, this can be useful in order to get a better dose in for the patient there. Just something to note. And again, it allows for basically them to get a higher proportion of more small and respirable particles, which is what we're looking for into the actual lungs. There's a really good study one time, which I wish I still had a copy of, but they actually had radio labeled medication coming out of a meter dose inhaler, and they looked at different techniques for inhalation from an MDI, and then they would take CT. I guess it wasn't CT scan necessary. It might have been. I don't know what the exact scan was, but they did a scan to see where the drug actually ended up. And a lot of the techniques that were poor actually ended up with a lot of drug in the stomach and not necessarily in the lungs. So it was kind of cool. You could actually visually see where the drugs were ending up there. Yeah, maybe it was a nuclear scan. Yeah, you probably might know more about that than I. I'd have to find the study though to confirm for sure. But anyway, so basically these patients here, when they're going to use their inhaler, basically first off, you always have them make sure they shake the inhaler up. The reason for that is because there's a mixture of drug and propellant in that canister, and they tend to be immiscible sometimes. So by shaking it up, you then put it back into solution, and you get a very uniform dose being administered there. You'll have the patients exhale, not full, hard exhalation, but at least get most of the air out of the airway there, and then you can hold the inhaler as shown. Most of the times, if you can put your mouth on the mouthpiece, that's usually a little bit better in order to facilitate good pathway there, but some patients may hold it further out. Obviously, the further out you get it, the more likely drug is just going to be lost to the atmosphere, which is not great. Basically, you'll have the patient as they kind of, what I have them do is actually start to breathe in slowly first, and then press down on the canister. The idea with that is you're already helping to start a nice airflow coming in from the atmosphere down into the lungs. That way the drug can kind of just get onto that same pathway, kind of like in Finding Nemo when they're following the turtles on the actual the water current, kind of like that. They're kind of hopping onto that current to get down into the lungs. And so then you have them breathe in over the course of about 5 seconds or so, have them hold their breath for about 10 seconds or as long as comfortable, which for some patients they may not be able to do 10 seconds, right? Just depending on what's going on. And then what I usually have them do is at least give about 30 seconds to maybe a minute between doses, right? So if you have like a typical albuterol inhaler, do 2 puffs, Q6 hours, PRN, make sure they separate those 2 puffs out a little bit. And the way I tell them is they get more bang for their buck because the first dose helps to kind of open things up a little bit, and you want to give that time to work. And then by the time they get the second dose, it's able to penetrate even deeper, get even better bronchodilation occurring there. I've seen some patients do both puffs at the same time, and I don't really think they get a whole lot of additional benefit from that. Okay, so overall, this is a chronic disease, right? So we're going to need long-term medications for prevention of symptoms. So that's your long-acting beta agonist, that's your inhaled corticosteroids, that's your leukotriene receptor antagonist, it's your IgE antibodies, all of that. And then the goal is to have them use their short-acting rescue inhaler as little as possible, right? Ideally, if they could forget it at home, that'd be great, because that way they would not show they're well controlled enough. They don't really need it that often. But one of the things you'll see too is that you can actually gauge how well a patient is controlled, because you may ask them when they come in, like, hey, how often, how well controlled your asthma on a scale of 1 to 10? They're like, oh, it's a 10, it's great, it's fine. But yet they're coming back in because they need a new prescription for their short-acting beta agonist. And they say, well, okay, well, do you need, a refill on your long-acting meds as well? And I said, no, I'm still good on that. Sometimes they're using their short-acting so frequently, they'll run out of refills early on that one, and yet they haven't really been filling their long-acting medications, and that's why they're so non-compliant, or evidence of their non-compliance, and why they need the short-acting beta agonist so frequently, because they're getting that short-acting effect, but not really helping themselves in the long run. So little things you can do to try to get a feel for how well controlled your patient is, because what they're telling you may not always be the whole picture, or even the right picture, as it turns out. And obviously, if you can avoid allergens, that'd be great. If you can do desensitization protocols and things like that, that's effective for your patient, then that could be another helpful thing as well. Okay, so there's also what we call status asthmaticus, and so this is not a spell from Harry Potter by any means, but it's a medical emergency that occurs when patients basically remain unresponsive to their initial bronchodilator treatment, right? And so basically, what we're going to start off with is higher doses of continuous albuterol. So instead of giving them, say, like a nebulizer over the course of like 10 or 15 minutes, we'll actually give them a continuous dose going over many hours potentially. The doses specifically, I don't really care that but they're getting a dose per hour basically of continuous albuterol. They'll also start off on IV steroids, because again, we want to make sure they get as much bioavailability as possible. And then the other thing too we can also administer, which is kind of neat, is the idea of giving magnesium sulfate. And you're like, well, why would you do it with magnesium? They don't have hypomagnesemia. They don't have torsades. Why are we going to do that? Well, if you recall, when I talked about this before, is that magnesium can kind of work like a natural calcium channel blocker and can actually allow for some smooth muscle relaxation in the bronchioles. And so typically we'll start off with like a bolus for the patient, see how they respond. If they're still not having a good enough response, we'll actually give them a continuous infusion afterwards in order to help kind of have a sustained sort of bronchodilation there. So that's another thing. You may see patients on a magnesium drip or getting a magnesium bolus in the ER. That's usually what it's going to be for in those cases there. And then also another really cool thing, which, we talked about ketamine briefly during our journal club the other day. We can actually utilize, now with that we're talking about S-ketamine. This is the racemic ketamine we're talking about here. If a patient is so severe that they have to be intubated just to have a ventilator breathe for them, and this is more so for patients who are like severely bronchoconstricted, or if they've been having such a hard time breathing for so long, they start to tire out. All those accessory muscles in the diaphragm are starting to tire out and they have to be intubated. This is where something like ketamine can actually be really useful here, because when patients are intubated, they typically have to be sedated, because again, having a tube down your throat is not super comfortable and patients will fight you on it. So by giving them a sedative and an analgesic, that allows for them to be more compliant with the ventilator, more synchronous with it. And we'll talk more about this next semester. But I mentioned ketamine here because it has a good use for asthma, specifically because of the fact that it does provide some bronchodilation, right? So we can use this for those patients there, get some additional benefit, which is kind of neat. And I'll talk more about ketamine next semester when we get into other sedatives. And then for like really even cases that are resistant to that, then that's where we can bust off things like aminophylline, which I mentioned is the IV form of theophylline. We used it rarely, but it can be used if you're in a pinch and nothing else is really working. So kind of have an idea of how you would manage that patient with status manicus. Realize that magnesium has a role to play here, but not for like routine exacerbations, things like that. All right, switching gears here. Next, we have our COPD patients. And so you're typically going to see that the management of this is going to be a little different than asthma, even though we're seeing a lot of the same medications here. But as you know, COPD is this kind of chronic inflammation and destruction of the airways. And again, the big difference here is that it's not always reversible, right? Because they've done damage through either smoking or whatever reason they have COPD now. And so the other thing too is they'll have this really long asymptomatic period. So even the function's decreasing, they have a lot of compensation that they can do for that. And so by the time you get to a point where they're symptomatic, you may have already lost a pretty decent amount of lung function that is not going to be reversible, right? So that's where things like supplemental oxygen and things like that are going to be so useful for these patients here. But we'll look at some ways we can also help manage them from the COPD standpoint, from a medication perspective, I should say. So obviously, big thing here is smoking cessation for them. I'll talk about that in more detail in a few moments here, making sure they're adequately vaccinated, which I'll get into. And then let's look at their stepwise approach to their drug therapy. Similar to asthma, you can start off with a short-acting beta agonist. Here you can actually, most patients will probably get albuterol by itself, or in some cases they may get ipratropium. Sometimes you'll actually see a combo of the two used together. So there are some inhalers that have a combination of ipratropium and albuterol. Probably not used as commonly though on an outpatient basis, but you may see it occasionally. And then for these patients, they can also get away with using a long-acting inhaled bronchodilator. So that means usually like a salmeterol or formoterol by itself. That's the difference here between asthma and COPD. These patients can get away with using long-acting beta agonists by itself. With asthma, you don't want to do that, okay? And then as patients become more severe, that's where you start to consider things like theophylline, because it tends to have a pretty decent effect on those patients. And then also consider using an inhaled corticosteroid plus that long-acting beta agonist, okay? Again, there's only so much our drugs can do here because of the irreversible nature of the damage having been done over the course of decades, right? As opposed to asthma, where it's a fully reversible sort of bronchoconstriction. And then you have to consider things like, oxygen, making sure they're getting supplemental oxygen there if necessary. Talk about things like surgery potentially, transplant, all of that is potentially on the table, which is sort of outside of our scope. I will tell you, though, that the worst burn I think I've ever seen in my entire life was a patient with COPD who was on oxygen. He was also a chronic smoker, which he should not have been smoking with his oxygen, and he also had a gas stove that he happened to be cooking over. And let me tell you what, spark, some gas, and oxygen makes for one big fire. And that guy, unfortunately, did not make it through that, but he was as crispy of a critter as I've ever seen. It was really, really awful. So definitely like smoking cessation, especially whether using oxygen, it's critical, critical, critical. So we talked briefly about smoking cessation at our last grand rounds, and so here I'm going to talk about more specifically about the medications we can use and whatnot. Now, we know smoking is a huge contributor to COPD, and you see this being responsible for a lot of cases here. And so what we want to do is to try to get them to quit, right? That's the obvious goal. And of course, like we mentioned, is that just telling someone, hey, stop smoking, not the most motivational type of interviewing you could do there, right? So a lot of it is trying to see how ready the patient is for quitting. You know, do they have a desire to quit? Things like that, to see how psychologically ready they are, because there is a physical component to this. There's a physical dependence they have on that, but there's also a psychological component of it too you have to really consider there. You know, so a lot of the reasons why patients fail is because they try to quit cold turkey. They go off of it, and then they have those physical withdrawals. They have the psychological dependence on it. Even the physical action of actually holding a cigarette can be something that is, you know, something to them. That's why some of the nicotine replacement products we have actually come as tiny inhalers that look like a cigarette. So they get that physical sort of action of holding something in their hands that they're so used to. They've been doing it for decades. I recall when I was an undergrad in college, that I had this guy, he's a chemistry professor, his name was Dr. Healy, and he was so old, I assumed that helium was named after him. But he was one of the old school kind of guys who would like draw on the chalkboard with an actual chalk for everything. And he actually would hold his or it looked like a cigarette he was holding the whole time, because as he was talking, he would just hold this chalk in his hand like a cigarette, and you could tell that he'd just been doing it for decades. So there's a physical component, a psychological component we have to deal with there, which is important. So getting into that, there's a variety of different products we have, some of which are trying to replace what they're missing, some of which are trying to affect the reward pathway, and then we'll also see some additional ways we can manage that. The big thing here is that combination therapy is super effective. When I say combination, I don't mean multiple drugs. What I'm talking about here is cognitive behavioral therapy plus using medications. We do see good synergy between the two. They work better together in order to help kind of reduce those cravings that they're having, reduce the physical withdrawal, and also address the psychological component, right? So why do patients get addicted to nicotine? Like, what is it about that nicotine that is so rewarding for them, that they just love it so much? Isabel saying, I knew a psychiatrist that would recommend sugar-free lollipops instead of a cigarette. That's great. Yeah, so they at least had that oral component being satisfied there. That's a good point. A lot of it has to do with this sort of mesocortical pathway in the brain that releases dopamine, right? There's this dopamine pathway here, and I'll talk about this a lot. We talk about like opioids in the future, if we talk about different reward pathways or different drugs that affect the reward pathway. But I always talk about the dopamine squirts, and for whatever reason, students really glommed onto that, and they thought it was they thought it was funny, and so it helped them to remember. So I keep mentioning it. But like, if you have like if you're like a carnivore and you love like a big juicy hamburger and you eat one, a lot of dopamine gets released all at once. Or if you smoke a cigarette, or if you have sex, or if you do a dose of heroin, all this dopamine is flooding the CNS, and you're like, wow, that was amazing. I want more of that, and I want it all the time. And so for some people who are more kind of prone to these sort of addictive patterns, either due to genetics or whatever the case may be, they have a dysregulation of this dopamine pathway. So what the goal is here is that we want to try to reset that a little bit. And so the problem is when you quit taking nicotine, all of a sudden that dopamine pathway is not being activated anymore. And so that's why they get those cravings. They're just like, man, I really want that effect back, along with all the other physical stuff they're experiencing as well. And so they want that dopamine hit again. And so by helping to re-regulate that, that can be a powerful way to help reduce cravings. And so that's where bupropion comes into play. And originally it was used as a antidepressant medication. And, a lot of antidepressant medications work by blocking reuptake of serotonin. Serotonin, think about as being like the happy neurotransmitter. On the other hand, though, bupropion was a little unique because it works on the reuptake of norepinephrine and dopamine. And so we've actually seen some benefits in not only dopamine or bupropion for use for like nicotine addiction, but also for things like eating disorders, like overeating disorders, and maybe even some cases for opioid disorders. So by re-establishing normal function of that dopamine pathway, instead of it being sort of like an all or nothing, like I get a dose of nicotine, it's like way up here, and then I try to stop cold turkey, and it's way down here at the bottom, it kind of resets things a little bit and kind of keeps things at the baseline. That's kind of how I think about it. And so this could be good for patients who have concomitant depression, right? They help manage that. However, it's not going to be great for some patients. So for instance, because of this additional norepinephrine effect you're getting here, this can predispose patients who have a history of seizures that can reduce their seizure threshold to make it more likely for them to have one. So you want to avoid this in patients with seizures. If they're taking any other medications for depression or a specific class called the monoamine oxidase inhibitors, which we'll talk about next semester, you'd want to avoid that. And if they're taking any medications that are also supporting that noradrenergic effect, so things like tricyclic antidepressants and venlafaxine. All these medications we're going to talk about next semester, so don't get too hung up on the drug names here, but the seizure disorder is a big one I want to focus on for our purposes, okay? Because again, it's one of those things, if you don't recognize it, then that could lead to them having worsened seizures, number of seizures, and so that can be a challenge there, okay? So yeah, so the other thing too is that if a patient were to accidentally, or say not accidentally, but say they fall off the bandwagon and they go back to smoking cigarettes, that's okay because nicotine is not really going to interact with this drug at all. So it's okay if they end up smoking. It's not going to be a problem. That's not going to be the case though for a few of the other drugs we're talking about here. So next up is our nicotine replacement agents. This definitely helps replace what they are physically missing. So it helps out with the physical withdrawal symptoms like anxiety, and restlessness and headache and depression, all of that, because it's replacing what they were normally using. The goal would be to sort of give them a replacement dose and then slowly titrate them down over the course of 6 to 12 weeks. Some people may need repeated courses. It just really depends there. And then the goal being that they would eventually wean themselves off completely. And so for some patients, they prefer the gum. For some people, they will use patches. Patches are nice because they provide a nice kind of consistent dose throughout the day, especially for patients who are kind of smoking throughout the day. They have the inhalers, which can help to get the physical sort of effects, as I kind of mentioned before. Problem though is that you do not want them to smoke while on these nicotine replacements, because then that will give them doses of nicotine that are way higher than what they're used to, and that can lead to some of these issues here, including hypertension, tachyarrhythmias, CNS effects, and get really anxious and just feel miserable. So definitely make sure they know if you're going to smoke, don't be using these at the same time. Make sure you take the patch off, or make sure you stop using the gum, because otherwise it's too much nicotine. Okay. And then one last drug here, it's called varenicline or Chantix. And so this is kind of the newest out of the bunch here. And so this is a partial nicotine receptor agonist. So the cool thing with this one is that it only partially activates the nicotine receptor and kind of binds onto the receptor pretty tightly. So it prevents nicotine from coming on and actually interacting with it. So the idea is because you have a partial agonist effect around, over the course of like 12 weeks or so, is the fact that you can kind of mitigate some of those physical withdrawal sensations. And also, because all the receptors are occupied, even if they smoke, they don't really get that additional benefit of that nicotine. So they don't really get that same reward that they were used to beforehand because the Chantix is sitting there blocking it. So kind of a unique sort of mechanism there. And if they smoke at the same time, that's okay. And actually how you start them off is that 1 week prior to the quit date, you'd have them start at the Chantix, and then they would quit smoking cigarettes or cigars, whatever they're smoking. And then they would continue on for 12 weeks. Okay. And again, it might not be a smoking thing. It could be, chew or snuff or something. My family is full of a lot of rednecks. It's hard to say, but chew and snuff and all of that was their tobacco du jour, and so this would also work for them, even if they don't have the smoking necessary. Nicotine is nicotine essentially. The interesting thing with this one though is the CNS side effects you're going to see with this one, and so they really talk about a lot of the sleep disturbances due to these really vivid dreams. One of my cousins was trying to quit smoking, or was trying to quit snuff, and he came up and he's like, "Hey man, you ever hear about the Chantix stuff?" And I said, "Yeah, I just learned about it in school. It was a couple years ago, maybe many years ago if I was still in school." And he's like, "Boy, those dreams are wild." For some people, they're wild enough they don't want to take it anymore because it's kind of nightmarish. But for some people, they're totally fine. They like them. It just depends, right? The other big thing to worry about are the black box warnings here, are the neuropsychiatric effects. So if they have a history of depression, suicidal ideations, this could be exacerbated by that. So you have to make sure either their depression is well managed, or let them know, hey, if you experience any of these things, call us up. Stop taking the med, because that can be Obviously not great if they're going to try to commit suicide or something. Yeah. I would recommend against that, Jackson, because who knows, maybe you have underlying depression that could be triggered by this. Who could say? That's why it's a black box warning. It's difficult to predict who might have these effects here, right? Most people have some degree of depression after taking my courses. Anyway, so looking at also immunizations here for these patients, again, because they have this sort of disrupted airway, the normal protections are not there. They've lost that ciliated mucosa that normally would be expelling things. They're at risk for infection. So specifically things like, pneumococcus for things like influenza. So vaccination is really important for them. So they should definitely make sure they get the pneumococcal vaccine and certainly get updated on their influenza vaccine yearly. Again, if you have not yet, and if you don't have any, anything preventing you from doing so, I recommend you go ahead and get that taken care of because again, flu season is coming up. So that's it for the palm section. If you have any questions, I'll be glad to take them now. Let me see. I don't see any questions on the sticky board. Do you guys have anything at all? I am not going to get started on the next section, just FYI. So what my game plan is for you guys to take a quick break. I need to get some lunch, and then we'll reconvene at 2:30 on Zoom so we can get our journal club started. And also, because I only got about 48 of you guys here, so if there are other people who are not watching live, even though they should be, they can be on time for the Zoom. I want to make sure everyone's there. So I apologize if it's a bummer. You guys have a bit of a break, but it's the nature of the game. So any questions at all from you guys? All right, fantastic. You guys have a good one, a good break, and I will see you at 2:30.